introduce our speaker today, I do want to take a moment to remind you of something important. Your NRBS membership is genuinely valuable. Okay. Beyond the community and the collegiality you experience here and in our meetings, NRBS is going to be offering local meetings, including our first gathering that's going to be held in New York City in July. But we're looking all over the country. We've been working with ISNR. We're going to be working with AAPB to put together like local meetings so that we can be more together. Um, so that our annual conference is scheduled for September 26th and 27th. It is going to be virtual, but we're really getting together a good cast. Tom Kalura is going to be talking about AI and where our field is going. So more coming about that. We're putting it together. Our podcast is growing very robustly. Dr. Rosenthal, who's been on our board forever, is also doing tons of podcasts. With NRBS, you get clinician support, free monthly webinars. Please consider joining. I recently listened to the podcast that Dr. Saul did with Barbara Minton. I got to tell you, watch it, listen to it. It's amazing. I know Barbara, and I didn't know all that stuff. I can highly recommend it. And speaking of value, our sponsors for today, Emilio is here. He and Jesus, our sponsors. Thank you so much for sponsoring this webinar and bringing David to us. They have donated a subscription of XLNTbrain to NRBS. The link will be in the chat. And I really encourage you to look at it. We've used it in our office. It really adds something to what you can offer to your clients. And David will be telling us more about that. It's an outstanding tool. It's a $1,200 or more value. Opening bid is $300. I really encourage you to take a bid. Okay, so it's my great pleasure to introduce David Imes. It really is a pleasure. He's built an impressive career at the intersection of neurophysiology, clinical practice, and concussion science. He started right in school. His master's thesis focused on using S-Loretta neurofeedback in relationship to concussion intervention. In addition, he's board certified, QEEG diplomat, neurofeedback, and he works at, I got to learn the name again because I knew it as a different name, Chesapeake Neurobehavioral Health. And some of us remember Chesapeake Neurofeedback associated with Harry Kerasidis. So David brings that history to us as well. In addition to that, he teaches for stress therapy solutions. He's got over a decade of hands-on expertise in applied neurotherapy. He's got research credentials. I'm not going to go into it. You can read his bio. We'd rather hear him talk. So with that, I'm going to move on to turning it over to David. I'm going to ask you, please put your questions in the chat. I will interrupt him when it seems like he's taking a breath, and we'll have time for Q&A at the end. Thank you, David. Nice to have you here.
Thank you. It is good to be here. Thank you for inviting me, Ange. And I'm going to hopefully successfully turn on my screen share. So, yes, my name is David Imes. Well, I guess technically my first name is Paul, which is the P. I'm only Paul when I'm in trouble. So that's often. So anyways, I go by David, and I'm here to talk about something that is close to my heart, which is XLNTbrain, and that is how it, especially due to how it relates to a mentor of mine, Harry Kerasidis, which we will talk about. But I'm here to talk about from baseline to recovery how neurocognitive testing and symptom tracking, which are provided by Excellent Brain Concussion Management, and how I'm here to talk about how that can be useful in acute concussion, although not just acute concussion, even more chronic post-concussive syndrome, as well as even just clinical neurotherapy, or I would even just say clinical work in general, neurotherapy or not. So here we go. So yes, for me, this is very much in memory of Harry Kerasidis, and it is a great honor to be here and participate in his legacy and speak on this platform, this tool, this uh, entire project that he built with the help of Emilio, who is here now today, and now running the show at Excellent Brain. Harry, as he describes himself, was not your typical neurologist. He had interests all over the place. He was a sleep specialist as well as clinical neurophysiologist. He did evoked potentials in clinic as well as QEEG. And then not only that, but he was applying these neuromodulation tools in a clinical neurology setting. And these included neurofeedback, they included TMS or PEMF, and he was often educating, teaching him for stress therapy solutions, as well as at different conferences. And he would attend ISNR, he would attend AAPB, he would go to American Academy of Neurology, all over the place. He wrote this book, Concussionology, which is, straight from the source, if you will, about his approach to concussions. And it's a great honor to be here. He passed suddenly due to a heart attack on March 7th, 2022. It's hard to believe it's now been over 4 years because it feels like yesterday in many respects. And so, yeah, that everything just suddenly changed after that. And I'll get into that story a little bit, as well as try to keep myself on time and on task. So, my goal here is to demonstrate the application and the utility of symptom tracking and computerized neurocognitive testing, which is provided by Excellent Brain. And you can see there's just this logo here. Jumping back one, this is the logo which is the logo on my shirt, which was given to me by Harry. It felt right. I had to wear that. Yes, here we are, and this is our goal, is to go through this. Now, before I dive further into it, I just want to give a sort of disclaimer and also a few disclosures. One, I'm describing these methods, and this is for educational and informational purposes. I encourage these tools, but there's more going on. So we have to, just consider these other factors that are contributing to the outcomes here. But this is based on relevant literature, my 15 years of experience, and clinically, and then also collaborations, various collaborations, especially the collaboration with Harry Kerasidis, the atypical neurologist he was. It is important, and I always like to emphasize that referral to the appropriate disciplines is important, especially when the challenge, the issue is going beyond perhaps our own individual scope, and so this is important for thorough patient care. A few disclosures: I'm, as Ange mentioned, I'm a licensed behavioral health clinician in Maryland. I teach continuing education and also participate in EEG quality review services for stress therapy solutions. I have various volunteer involvements with the International Society for Neuroregulation and Research, ISNR, which is a developing project, which I'm excited about. And then I'm also excited to say that I'm a new board member of NRBS, that I'm not on the website, but I will be, and it's coming. And so I also just have to say that I'm not employed by Excellent Brain Concussion Management. I am wearing a shirt, but the logo is a bit dated. I also find it important to emphasize my scope of practice, or my limits, uh, and that includes who and what I am not. So clearly, I'm not Harry Kerasidis. I'm also not a neurologist. I'm not a physician or a prescriber or any type of medical provider. I'm not an athletic trainer. I'm not a psychologist. I'm not an ASET registered EEG technologist, or EEGT. That said, I have been doing this for quite a while, and I very much enjoy what I do. But I just find it important to lay that out. But to reference Harry, I'm not your typical licensed mental health counselor either. So a little about me is, as Ange said, I work at Chesapeake Neurobehavioral Health. We are a behavioral health practice in what's Owings, Maryland. So about 45 minutes southeast of Washington, D.C., in a pocket of Maryland called Southern Maryland, which frankly is a pocket of Maryland that most of Maryland doesn't know exists, but that's okay. Uh, and I'm a counselor who likes brain stuff, and I've worked with said brain stuff in various applications, clinical populations, both in clinical neurology, in Dr. Kerasidis' neurology practice, Chesapeake Neurology Associates, and then also applied this in a behavioral health setting, because essentially when he passed, we had to pivot. We pivoted from neurology, clinical neurology, to behavioral health, as the name suggests. I've done a few specialized projects in concussion, especially and then even addiction, which I'll actually reference a little bit later. As Ange mentioned, I'm certified neurofeedback, diplomate in QEEG, and yes, I'm an LCPC. At least that's how Maryland calls it. Otherwise, it's often called LPC. And then I spend a lot of my time writing QEEG reports or doing neurotherapy or even some traditional psychotherapy. Uh, Personally, I've had this long-standing interest in the brain. The brain and even the nervous system just it refuses to leave me alone, so I'm not leaving it alone. I went to the University of Maryland for undergrad and then Towson University just outside of Baltimore for graduate school. I always knew that I wanted to study the brain. That really started for me around age 10 after my grandfather, my mom's father, was diagnosed with Parkinson's. My paternal grandfather had some mini stroke events. My father uh, declined and passed due to ALS, or amyotrophic lateral sclerosis, Lou Gehrig's disease. And along with that, he had frontotemporal dementia. And so that was, again, very close to home in terms of the neurology and nervous system. And then even my son has some neurological elements. He got he got capped, and we recorded a QEEG while he's watching cartoons on a Sunday morning a few weeks ago. Don't need to go into that now, but yeah, like I said, this nervous system refuses to leave me alone. It's personal. Uh, my undergraduate degree is in physiology and neurobiology. I became an EEG technologist at a hospital, a regional hospital, uh, in my kind of my last semester of undergrad. And I was doing studies in the hospital, outpatient. In the hospital. Sometimes I was in just the typical med surg floors. I rarely would go into the ER. Sometimes I would end up in the ICU or the psych ward. There's some extreme cases in the ICU, such as a case of electrocerebral silence, where there's literally nothing. Everything looked flat in terms of the channels. So it's been a very interesting process. Uh, my graduate degree, after working this way, is in clinical psych, and through this time, overlapping the space after my undergrad, and then even through grad school, um, I was fortunate and blessed enough to be in the right place at the right time to have 10 years in Harry's orbit. And so I spent 10 years in his EEG, QEEG lab, learning from him. I remember the first time he sat me down and showed me another perspective on the brainwave data that I had been recording for, a couple of years, or probably about 18 months at the time. And I was hooked. And at this point, I've been sticking electrodes on people's heads for about 15 years, and just doing various things with that. And it just really grabbed my attention because a typical hospital grade, or not even hospital grade, but a typical neurology grade EEG report is a lot of words, very little visuals. And then here's Harry's report with all these colorful images, and yes, there's even an image of the brain activity versus just words about it. So really getting into it and looking at what's actually happening. And I just thought that was so cool. This is, one of his reports from a case however long ago. And so yes, the QEEG report and versus the EEG report, so interesting. And I was hooked. So I just got further and further into assessing, the organ in question when we're talking, of course, about neurology, but as well as, mental health, behavioral health, the brain. There's, of course, a lot of different ways we can do that. Even just visual inspection and finding incidental epileptiform activity, or looking at the spectra, running it through a quantitative QEEG database to get population statistics. And so along in that process, Harry had also come up with XLNTbrain, and we were using that in the clinic. And this was helpful to look at the symptoms as well as cognitive performance of the person. And we would use this in the clinic, and I'll describe it a little bit more, but we would use it broadly, but very much in focus on concussions, acute concussion, as well as TBI or mild TBI, in cases that were more chronic head injury. Um, the XLNTbrain platform, amongst the many different tools that it does have in the package, there are two that I will especially focus on today. That is the symptom checklist or the symptom tracker, as well as the computerized cognitive test. The symptom checklist, I will show it in a moment, but it is a subjective or self-report Likert scale, where somebody's rating how present their symptoms are, they're asked about them. And this gives us scores, and this references a total score where everything is added up, but then there's also a migraine, cognitive, worry, mood, sleep, vestibular, and anger score. And then we have a cognitive test, of which the symptom tracker is a part of. And the cognitive test gives verbal processing score, verbal memory score, nonverbal processing, nonverbal memory, attention, and emotional reactivity. And it puts it into a nice visual. And this is showing us a few, actually, uh, two at once. And as we move from a slide where I'm talking about the goal of what I'm talking about, or of this presentation today, this is a case study from a 12-year-old soccer goalie. She had two impacts, one day apart. She actually had a history of a few, but when she received the first impact, she stayed in the game, and then the second impact came the next day. So as we look at this, we're seeing the post-injury or after injury data in the top row, and then the post-recovery 44 days later in the bottom row. One of the labels got chopped off. Sorry about that. And what we are seeing, or a few of them actually, but what we are seeing in the symptom checklist in the first column is this radar graph where further from center is a higher score or a higher symptom, and closer to the bullseye is a lower score, lower symptom, lower rating of issue. And after the injury, this person is identifying that they're on the symptom checklist, that they're having issues with migraine type symptoms. But then by the recovery, these have largely improved. Actually, they're all now in the bullseye with this symptom checklist. After the injury, we can see that their scores for verbal processing, verbal memory, nonverbal processing, nonverbal memory, emotional reactivity, and attention. And the accuracy by recovery has all improved, moved towards the bullseye, towards the center. Red dots suggest abnormality. Yellow is borderline, and green is typical or within the normal range based on the stats and the normative data for the computerized cognitive test. And I should say that the cognitive test is about 30 to 40 minutes. It is blending quite a few different tasks. I'm not gonna go very far into the detail about that. I'll leave that to Emilio in the website. And at the same time, there is a lot there that we could talk about. But we can see that by the recovery, the verbal processing and verbal memory scores have gone down. They have moved from red to green. The attention score has moved from borderline towards green, and even the typical scores that were green have all moved in towards the center. Each score improves. The efficiency column is about speed. or the efficiency with which the individual achieves this accuracy in this third column. So we're seeing how fast are they achieving on each of these. And at injury, the efficiency scores are as so, and by the end, they've all improved as well. So we can see very clearly that from post-injury or after this goalie sustained 2 injuries within 2 days, which disrupted her comfort, especially in terms of migraine, but even disrupted sleep and mood to a degree. We also have disturbances in cognitive performance, and all of this improves by the time that this person is recovered and cleared cleared neurologically, I should add, by Henry. Wrong way. And this is the symptom checklist that expands out over time. As I said, the symptom checklist is able to, or is integrated into the computerized cognitive test. It's actually the first portion. However, the symptom checklist is available on an app. There's an app for that. Actually, there's a lot in the app. And conveniently, this symptom checklist can be taken in just a matter of minutes, and it can be taken daily, as this person did. And this person took it daily for about 2 months. No, just about a month, those 44 days. And we can see high scores for the total, which is the tallest bar. And we can see these scores all decrease eventually down to 0. And it extends for so long until they're cleared because of the progressive exertion protocol, which we'll get to. But we can see here a nice change over time, or a decrease in this individual's concussion-related symptoms. And on the graph, especially on the online or in the app, you can even toggle on or off different symptom clusters and look at only the graph or only the data for that score variable for that symptom cluster. And so we're seeing right here the after injury computerized data for the symptom checklist and the test, but the overall decline or decrease in this individual's symptoms as they are eventually improved enough that they are cleared. And I should add, that was just a post-injury and then comparison to a post-recovery test. But ideally, and the way that Harry was especially trying to teach and broadcast XLNTbrain, this isn't just used after injury. Ideally, people take this test at baseline, pre-season, almost like that physical from the pediatrician that has to be signed off in order for the athlete to play. At baseline, this 15-year-old wrestler looked as such, maybe some migraine symptoms, but by the time that we recover, we're looking a lot more like our baseline after these disturbances from injury. And we can see here, even in the efficiency scores, the verbal memory speed slows down, but then actually improves. And so we're getting some real hard data, and even in terms of the accuracy, a return towards baseline, although there is some movement around it, especially in terms of the cognitive scores. So again, this isn't just for intervention in terms of the acute phase of the injury, especially with concussion. This holds value pre-season, or even imagine being able to do this over the years as this wrestler continues to play, if they continue to, or I should say, compete. In the clinic, Dr. Kerasidis worked to evaluate people in the office as quickly after the injury as they could. They would hold slots in his schedule for acute concussion. And there's often balanced testing through XLNTbrain, the app. The EEG/QEEG was part of this. There is also a vestibular auto rotation test to measure eye tracking. And then different medication management and or supplements would be implemented. And then there was a process where the athlete would return to play or return to their new baseline, as we might think about it. And this was all facilitated through Dr. Kerasidis, as well as other providers. It wasn't just him, but other providers, as well as licensed athletic trainers in the clinic. Those were R. In my mind, it's still active, but it's not. Stacy Rector and Steph Guzza, both of whom I believe are involved in Excellent Brain to this day, and have done a lot of work over the years for this project. But as I'm explaining, Excellent Brain was developed and then also deployed in this context. Now, just to speak about concussion, before I get into some of the data, we have to remember that concussion is a brain injury, and it's this complex pathophysiological process that is induced by biomechanical forces, and this is what's affecting the brain. And this biomechanical trauma from concussion is creating an ionic and a metabolic energy crisis in the brain. And this presents these acute and chronic physical and mental health challenges. And there are even changes to cerebral blood flow with distinct patterns in that cerebral blood flow that emerge between different symptom clusters. So there are certain clusters of symptoms that can show up specifically in the fMRI research, is what that point is saying. And one thing to add is that the brain continues to recover after the athlete is cleared of concussion and successfully returned to play. It really makes you think hard about, even though we're cleared, how much progress is there still to be made? When should we play? And these are just rhetorical / hypothetical questions, but it's worth thinking about. And there's some important statistics that I've just pulled from the Excellent Brain website, to be honest, where we are looking at the incidence. According to the CDC estimates, they're up to about 3.8 million concussions per year, sports concussions especially. The deaths related to concussion are rivaling or overcoming those of AIDS. Concussions can occur in 10% of all contact sports athletes. And so it is this very serious and potentially life-threatening condition, and it's affecting millions every year. And these are the ones that are reported. There's plenty more, I'm sure, that are not reported or perhaps shrugged off. We're told to dig deep and get back on the field. This is a real serious thing. And it could be prevented or at least better managed. And this is where I think Excellent Brain becomes so important. And this is why Harry was doing what he was doing with it. And to think also about the nature of concussion injury, there is this direct blow to the head, but it can also be a transmitted impulsive force, such as a whiplash injury from a rear end accident in a car. There's then a rapid onset of symptoms that are reflecting a functional disturbance. And this is happening because the neurological functioning underneath is impaired. And one thing that's very important to note is this is typically not appearing on standard neuroimaging methods, such as CT or MRI. Those are what would typically be deployed or used in an emergency room setting. Fortunately, there isn't something showing up on those. If there is, there's a larger issue, like a fracture or a bleed. However, those are more extreme, and concussion is slotting into this, what feels almost like a no man's land to a degree. But there's a lot of possible symptoms, as you see listed, and there's potentially headaches or impaired cognition, irritability or emotional ability, mood swings, disturbances in sleep, consciousness, memory issues like amnesia. We can have balance challenges, nausea or vomiting, or even just fatigue. Some people will literally say, I feel like I'm crazy. And it's like, no, they've actually hit their head and they are feeling then the effects. They're not crazy. And I'm just quoting people that I've worked with over the years that will say that. And it's especially concerning in youth. It's concerning across the board, but the younger brain is more vulnerable to concussion and the recovery may take longer. Not to mention that the concussion itself is disrupting typical cortical plasticity and functioning, and it's impairing function as development continues. Football, soccer, rugby, and hockey are reporting the highest incidence rates. And then down the line, academics and even other athletics may be impacted by not only this concussion in the acute phase, but then as well also the recovery or even longer term effects. Now, there are concussion recovery guidelines from the consensus statements, and Excellent Brain was developed in accordance with these. Typically, This recovery is taking 10 to 14 days in adults, 4 weeks in children, although there is more and more evidence that some adolescents and younger athletes are requiring longer, or young adult athletes are requiring longer than those 10 days. Physical and cognitive rest are the most widely used treatment interventions, but there can be others. And there is this gentle return to play as people increase exertion while remaining symptom free. And once they're able to exert at full physical output without provoking symptoms, that's when they're cleared. And this is straight from one of Harry's presentations, just to give an example of how a 5-step progressive exertion could look, where we move from light aerobic exercise to maybe a low level drill to, or an exercise, I should say, and then maybe it's a contact drill. And now we've gotten perhaps into a more specific and aggressive practice, and then we can get to a full contact practice. If we can get through each of those steps without symptoms, we move towards clearance. However, if step 1 provokes symptoms, we stay at rest. If step 4 provokes symptoms, we stay at step 3 until we can move up. And so here is a different wrestler with 2 impacts about 5 days apart that right after injury complains of headaches, challenges with focus, and there's even dizziness and fatigue. Uh, on the symptom checklist, we're seeing issues with migraine as they report, and this is paraphrasing from the clinical note or the intake note, but there's migraine showing up as well as cognitive challenges. Their sleep is disturbed as well, which is probably not helping the fatigue. And then the vestibular score also stands out. By the recovery, 58 days later, all the scores have gone down. We also see the post-injury scores compared for accuracy compared to the post-recovery, where we see many of the post-injury scores progress and moved closer towards the center, which suggests improvement, while some of the other scores, like the attention, stay in about the same place. But we have the verbal processing, verbal memory scores that improve, the verbal processing being the furthest from the center or the most elevated, and then the nonverbal processing and nonverbal memory scores move in as well. And with efficiency, we're further out. And so we're also moving slower at the injury compared to the recovery, where our accuracy improves as well as our efficiency or our speed as we move through the test. And this individual was very diligent with their symptom checklist. They filled it out a lot. Not everyone is this consistent. It's very nice when they are. But we can see that the scores right after injury were quite high and they gradually fall. It's a little lost in the data, but we can see that there is an elevation here with a lot of the blue, and there's a few peaks right up in these spots, which in my experience, there's something that's happened here. Maybe a stressful event or a stressful life event. Maybe they overexerted and provoked symptoms, and this is reflected in the symptom checklist. But here by the end, we can see that these are all the scores at 0. And we can introduce the QEEG data as well. And this is where I think we're really looking at what's actually going on. In this same wrestler, by the end of the recovery, what was increased slow wave delta activity, especially in temporal regions, but also the right parietal region, this has improved, at least in the left temporal, but it's still elevated parietally. Well, when we think about the changes in symptoms, we are seeing overall a shift in the brain's regulation. There is still some slowing in posterior regions of the head that support processing, sensory integration, visual processing, and yes, memory. And yet we don't know what this individual's baseline looked like. We don't know if this is a return towards their typical functioning, at least in terms of their brainwave signatures in that delta range. But overall, there's a reduction in the z-score or the normative statistic for this delta activity by the time we get to the recovery. Analysis through a different QEEG database called QEEG-Pro shows an overall reduction in this delta activity as well. And there's actually a deficiency in the frontal region. It'd be interesting to look at this change over time, even further out after the recovery. And we also see reduction in theta activity. the delta being the 1 to 4 hertz range, theta being 4 to 8 hertz range. We're seeing increased theta activity in the right temporal region that has improved significantly. The only thing that's, or the highest point in terms of the theta activity, is now in the left occipital region. And at least by my standards, it's statistically not significant. Overall, we're seeing improvements to the brainwave measures. But what stands out, and I'll jump back, after injury, the highest value in terms of this slow wave delta activity is in the left temporal region, which supports verbal memory, verbal processing. And we see those improve. And we see it move away from that left temporal region. However, there are still delta findings in those sensory integration ranges. And we still have, we have improvements, but it's interesting that it's now over on the right side, which is supporting the nonverbal tasks in terms of cortical overlap, or overlap of cortical function with presentation. And so within EEG, we're looking at these different frequencies, much like white light going through a prism and breaking down into the rainbow. We're taking brain activity and looking at its component frequency ranges and thinking about what those mean, and then trying to understand how this relates to the presentation. We're using the EEG with this, and then putting the population statistics behind it to get colorful maps. And we're getting a normative reference that's not the expectation necessarily, because of individual differences, but it's a very helpful reference. And we would do EEG research. We were working actively on research at the time of his passing, actually. We were collecting EEGs as close to injury as possible, and we were validating the existing research using, and this is the S-Thoretta algorithm. That's what we were using at the time from the NYU BrainDX QEEG database. We were seeing these elevated delta patterns, as well as theta. We were seeing improvements in activity that persisted past recovery. And it's important to note that this was even showing up because, again, the typical neuroimaging methods are not showing us anything, at least in terms of this brain sprain. And we even did some gender differences analysis, which was showing there were possible compensatory mechanisms due to some of the differences between male and female athletes. And this is important because, according to the research, girls are typically experiencing higher rates of concussion in sports that are played by both sexes. One thing that Harry would often say, though, is that if you've seen one concussion, you've seen one concussion, that one, because they are all so different. And here is a demonstration of how, after injury, we are seeing elevated delta and theta activity in the left column. And after recovery, it has improved. Less delta activity in the left frontal, left temporal, bilateral occipital, I should say bilateral temporal. By recovery, there is still elevated delta activity in the right temporal region and left frontal temporal, but it's still there, even though we are doing much better. Now, again, we don't know how this compares to an individual's baseline, but we can see that there is still this finding showing up. In terms of theta activity, we see increased theta in the left temporal, frontotemporal area that does improve, but it still shows up. However, sometimes you get lucky and you do have a baseline on an individual. This is from an individual that had come through the neurology clinic for treatment for migraines, and actually did some neurofeedback, SMR neurofeedback to support her migraines. And this is under the direction of Dr. Kerasidis, because as a counselor, I can't treat migraines. He could. And so we have in the left column, as I've kind of broken my table down to make it fit on the slide, the left column showing a QEEG baseline from almost exactly 1 year before the injury. After the concussion, we see these changes in the center column. And then after the recovery, which is about 22 days for this individual, we see improvement in many of the signatures, and the specific EEG patterns for this individual were atypical. They had things like a fast posterior dominant rhythm and various other features. So they challenged the database in that way, hence its reference as a useful tool, but perhaps not the expectation. But we can see that after injury, or pardon me, after recovery, their data looks a lot like their baseline. And we can also see that the increased delta and theta activity that was present after the injury has gone down. So every now and then, and really this is the one that's the most clear, there can be value, or there can be this opportunity to look at what is a baseline in terms of brain activity, and how does that compare to post injury, and then how does that compare to recovery, much like Excellent Brain is offering in terms of the cognitive performance. And this is what that person's cognitive performance looked like, as well as their symptom checklist. Now, I don't have this is not their baseline cognitive performance. This in the bottom is showing an overlap of their cognitive scores and symptom checklist, where the blue shaded area is after injury, and the dots, or squares, actually, the green squares with the gray lines, is after recovery. All of those being closer to the center of the bullseye are showing that compared to after their injury, their performance cognitively after the injury, we've seen improvement over time as they are recovered. We also see their symptoms gradually decrease over those roughly 22, 25 days. I like to think about a lot of this through the law of conservation of energy. Energy is neither created nor destroyed, it's transferred or converted to something else. And much like our cars, or at least the gas burning ones, are converting motion into wheels, or converting that gasoline into a motion that turns the wheels and helps us get somewhere. And then the brakes are converting those spinning wheels into heat. What we do influences how we feel, and how we feel influences what we do. In that vein, neurotherapy offers a lot, and this isn't the full list, but there are things like neurofeedback and magnetic stimulation, photobiomodulation, audiovisual entrainment, heart rate variability. Yes, I know that's about the heart, and yet we need the vagus nerve, which is running up north, let's say, for that heart rate variability to have the effect that it is. To focus on neurofeedback, preaching to the choir here, perhaps. But again, this main idea is that we are reinforcing optimal functioning and teaching that over time, or rather, the individual going through the neurofeedback is learning it through repeated sessions. And this is neuroplasticity in real life, taught, if you will. And the QEEG is demonstrating these changes over time. This is not related to concussion, but down here, QEEG is 2 months apart for an individual with severe anxiety, and after 2 months of alpha training, remeasuring them with the QEEG shows an increase in the alpha. And I say an increase because the blue is showing a deficit or a deficiency in that alpha activity. As their brain learns to make more alpha activity, there's less of a deficit. This analysis is showing us the most extreme, not only z-scores, but also volume of the projection of the EEG data onto this 3D model. And the reason I'm bringing this up is because Excellent Brain goes beyond concussion. We've been using it this way for many years. I still use it this way. We use Excellent Brain, the cognitive test, regularly, presently in the clinic, and we did before Harry's passing as well. This is a 57-year-old female coming in because they're struggling with ADHD symptoms. They have challenges with emotion regulation, even dysthymic disorder and generalized anxiety, depressive. There is a history of trauma that we talked about that had been overlooked for years. But regardless, as they come in and complete their assessment process, which does include the Excellent Brain cognitive test, as well as other more traditional measures that I'm not getting to here, other self-report, as well as a QEEG, we see their symptom scores before a series of neurofeedback are further out, especially identifying challenges with the cognitive score, as well as sleep, mood, vestibular, and migraine scores. By the end, in this symptom checklist column, we see improvements to the cognitive and migraine score. The migraine actually looks about the same, but the cognitive score has come in, and the rest that were red are now green. Even though some, like the sleep, the green is still further out from center, it's the way that the scores are adding up that they're perhaps noticing certain challenges but it's not that they are as extreme as they were. They're not as much in the way. And over time, we see their symptom checklist. Again, we only use this checklist twice for this individual, but we can see a reduction in their total score from 46 down to 27. They're feeling better as they report on this. And I'll tell you, in my, just working with this individual clinically, they were feeling better. And it's more than this, but this really complemented it. We can see that their accuracy and efficiency scores, there's some challenge. Still, by the end, I think some of this was, let's say, technological literacy. And we also have accuracy in verbal processing and verbal memory as the most outstanding scores at baseline and after the series of neurofeedback. The efficiency scores are still far out. However, as we move slow, we're getting more accurately. And I say slow because, again, higher efficiency scores mean that it's a slower response. And I will tell you that there are times, I don't have any here, but where we will see an accuracy score from pre to post, the accuracy improves, and sometimes the efficiency goes down or it looks worse. Is that actually worse though? If you have somebody who's rushing through the test and now they have figured out a way to regulate differently, slow themselves down and become more accurate, maybe slow is smooth and smooth is fast. For this individual's QEEG data, which shows up especially in their temporal regions bilaterally, these are just multiple angles, it's prominent in the theta range, as well as a lot of high beta or beta gamma activity around 35 hertz. Beta gamma is a word of a phrasing that Harry and I would use often. But we can see that these actually all improve. And I just show them here because these are the baseline measures, but they improve to the point that they're not showing up on the post assessment because we more or less draw a threshold in the software and only see anything that is greater than a positive or a negative 2.5 z-scores or standard deviations. So by the end of the neurofeedback series, which was z-score neurofeedback in the bilateral temporal regions, as well as parietal, as well as some alpha theta training, we just see a difference in their regulation or their brain's regulation by the end. And we see that reflected in the computer test and symptom tests as well. There are, I should add, charts within XLNTbrain and the output reports that give the data for each task that I'm not showing here. But to correlate what we're seeing in the data, we're seeing differences in areas that support emotion regulation, processing, and there are, amongst other, let's say, clinical features. And some of these improve. Some of them are still an issue. But I will say that this person moved on to other, therapies and other options, and they continued their journey, but they were regulating differently. Here, it's being applied in the context of ADHD, where the symptom checklist of a 14-year-old male with inattentive ADHD and a very addictive screen behavior, and then after that would also have challenges with regulation of emotion and behavior, which was mainly when being forced to stop using the screen. We see a change over time. The symptoms in the symptom checklist gradually go down. We see this when we really focus on the pre and post scores of the checklist. Their sleep is the more outstanding score, while the others are improved. Consistently, though, or I should say that in terms of the cognitive test data, they're fairly consistent. A very similar display or a very similar pattern overall. Their QEEG data improved dramatically. We see a very different regulation. They've found a way, let's say in terms of regulation, to slow down. And now it's interesting, at least to me, that the way that this increased alpha in the relative power stands out, which would be, informative for future steps. And those future steps could be supported by more cognitive testing, more symptom checklists as things progress. This is kind of my last demonstration, but along with the concussion work, just over the years, I was able to do a pilot program for about 2 years where I was taking neurofeedback to a small group of women going through court-mandated treatment. And I was following existing neurofeedback research for substance abuse, the Bill Scott protocol, which built on the Peniston-Kolkowski alpha theta neurofeedback. This is essentially beta SMR neurofeedback at C3 and C4, and then alpha theta neurofeedback at PZ. And we would do these twice a week as consistently as possible. And I would go to them in the evening when their group would meet twice a week. And as I wired them up, what would I do? Pull up my phone, log them into their de-identified and anonymous Excellent Brain protocol, or pardon me, Excellent Brain account, and they would fill out their symptom checklist, and then we would run their neurofeedback sessions. And this shows just overall that case one, their symptoms gradually reduce over the course of the neurofeedback sessions, as well as case two, gradually decreasing. Still there. They're still, have their challenges in various ways, but gradually improving. And just trying to show that, again, this tool has application very much within concussion as it was developed, but it also goes beyond that. And this is a long-term look at a third case that happened to be involved in the first pilot, or the first year, and then the second pilot. This is only showing the beta and high beta frequencies for the eyes closed and then the eyes open. This could be labeled better, I admit. And we can just see at the first QEEG in the first pilot, at the beginning of the first pilot to the end of the first pilot, we have increased beta that then goes down. And this individual does have a fast PDR that I want to say was in the range of 13 to 14 hertz. It was quick. And then by the beginning of the third pilot, which was about a year later, these would run over winter. It was like 2018 into 2019, and then 2019 into 2020. Like right before everything shut down with COVID, it was like the week before I had just gone back to the drug court and like presented all the findings, and then it just kind of stopped. Anyways, we can see just a decrease in the brainwave data.
And David, you got 5 minutes left.
Thank you.
A couple of questions.
I'm wrapping up. Yeah. Essentially, this one, what I'm trying to show is their scores go up. And we have a lot of activation. And this person definitely had complex PTSD in their past. I was not the clinician in this. I was just coming in as a neurofeedback specialist, if you will. But there was more to be done here. And so I even found that the ways that these scores increased to be meaningful, as well as even validating with the continued elevations in the beta activity. So trying to wrap it up and get out of my own way here. If you've seen one concussion, you've seen one concussion, as Harry would often say, but these symptoms are reflecting a functional disturbance that is this brain sprain. And this injury is often eluding typical approaches, and they vary a lot between individuals. This impairment can be objectively measured in the cognitive performance, baseline versus injury versus recovery, and we can also use symptom tracking to show this progression, and it is useful for the ups and the downs of recovery. And this can be complemented by other tools like the QEEG, and I will add that it is clinically very validating and liberating and healing for the concussed person to see all this information. Overall, this testing and tracking is showing objective measurements of the cognitive performance, subjective reporting of the symptoms, and we get these nice longitudinal graphs, and both are guiding the process. And I would say relevant to any therapy, whether it's neurotherapy, psychotherapy, trauma therapy, pharmacological therapy. In the clinic, in the neurology clinic, pharmacological therapy was, part of the play. It's interesting to see a symptom checklist graph suddenly shift when a new medication has begun. These tools complement the picture, and as well as the other measurements that can include the QEEG. And I like to mentally, this is how I'm thinking about it. I'm overlapping the brain data with what we're looking at on the cognitive scores. And these even kind of line up. I mean, I could shuffle it a little bit, but we're looking at verbal memory on the left side, nonverbal memory on the right side, nonverbal processing more right posterior, verbal processing more left posterior. The emotional reactivity is to do with a facial recognition task. That's probably more right posterior region, but the attention in the parietal region. I mean, there's an overlap here, and we're even seeing the symptoms show up as well. So trying to superimpose them. But overall, we have this brain between our ears. It's this physical medium of the mind, but it's vulnerable to insult, whether that's physical or psychological. And we can assess and measure this using different tools such as cognitive performance or self-report or the electrophysiology, and then look at the overlap and observe over time. and then use it in the right setting, in the relevant setting. And I think most importantly, inform and validate the right people, such as the patient and client, or the client, the family, the coach, the educator, or the clinician. Thank you. That's Harry presenting uh, at one of probably an ISNR conference. And actually, I'll just add, here's me years ago. My brother worked at the practice for a while. This is Harry's youngest daughter, Tasia. She is actually just finished med school, neurology. So Dr. Kerasidis was not the last Dr. Kerasidis. Steph Guzzo and Stacy Brecken. So all of us involved.
Oh,
And then Harry
beautiful. Beautiful.
himself.
Thank you so much. I do have there's a couple of quick questions. You alluded to it doesn't take long to administer. What's the length of time for a patient once they've taken it once to do the retest?
Oh, it's yeah, in terms of the cognitive test, I would say it's usually going to be in that like 30 to 40 minutes range, like day 40, 45. And then like we will typically in clinic schedule for an hour, and if the full hour is usually not needed.
Gotcha.
It's hard. I'll usually warn people that they walk, and it's supposed to be hard, right? But most people are, you're walking out feeling less intelligent than when you walked in. But that's the point.
Yeah. Yeah, very good. This is wonderful. Thank you for bringing this to us, and thank you also, Excellent Brain folks, for your support of NRBS. There is a bid on the silent auction, so get in there, guys. I did want to ask, do you know the answer, David? If you win the silent auction, how many tests, retests do you get, or does Amelia have to answer that?
It's unlimited, Angelica.
Unlimited.
Yeah,
Excellent.
the
Okay.
subscription that we offer to everybody is unlimited testing, like baseline testing, post-injury testing, and then like the post-exertion process and everything. Like it would be like unlimited. So
Awesome.
and also
Awesome.
you also have like unlimited users, let's say like athletes. So that's how
Awesome.
it would work. Yeah.
Okay. If you need to know how to make that monetize in your practice, let me know. I can help you with that. But this is an excellent offer, and I'm
Yeah.
so glad we got to see, how useful it can be clinically. Really appreciate it. Thank you, everybody. So with that, the recording will be out in a few days, and the auction is open. So thank you so much, everybody, for joining us. Have a good rest of it's early in the week. Good rest of the week.
Thank you for
Thanks
having
a
me.
lot. Have a great day. Bye.
Take care, everyone.